not everyone wants to stop using drugs right now, or maybe ever. Not everyone wants to be in recovery, but everyone wants to be safe.
You're listening to Narcotica, a podcast giving you the straight dope about drugs and the people who use them.
Welcome to Narcotica, everyone. I'm Troy Farah, here with Christopher Maraff and Zachary Siegel. Today, we're going to be talking about supervised injection, or supervised consumption, with Laura Thomas of the Drug Policy Alliance in San Francisco.
Laura, in the past couple weeks, there seems to have sort of been almost like an inflection point in the supervised consumption services debate. So there was this meta-analysis that came out, and there was a lot of controversy around that. It basically found that there were, quote, minimal effects when it came to reducing overdose deaths at the population level. And then shortly after that, Rosenstein, Deputy Attorney General at the Justice Department, he came out with an op-ed in the Times. The headline is "Fight Drug Abuse, Don't Subsidize It." We all know what he's saying there. And so I think given those two events, on top of the exciting news happening in San Francisco, California especially, there's a bill waiting to be signed by Governor Jerry Brown. I think we wanted to take this time to sort of take a 30,000-foot view of this issue right now. And so we're really excited to have you on. And I think more than anybody, the political climate, the science, the policy. So I guess, where do you think we should start?
I hardly even know where to start. I mean, I've been working on this issue since 2007, and my work on supervised injection predates my employment with the Drug Policy Alliance. So this is something I've been working on since before then. And in 2007, a coalition we called ourselves the Alliance for Saving Lives. We came up with this idea to do a day-long community forum here in San Francisco. We got the Department of Public Health to co-sponsor it with us. We brought a couple of people down from Vancouver, and we had a whole day-long community forum talking about overdose deaths, about HIV, about public safety. We had, Sarah Evans, who was then running Insight, and Thomas Kerr, one of the leading researchers on it, talk about what was happening in Canada. And it got some good media, and we were all very happy about it, except that media quickly turned on us, and the story got picked up by the right-wing talk radio circuit, and they started amping up their viewers to complain that, San Francisco was opening crack dens, and San Francisco was going to be handing out illegal drugs to people, and all of this stuff. And the health departments, voicemails filled up with angry people calling from Indiana, upset about this. And it got so bad that Senator Jim DeMint, then the senator from South Carolina, introduced or threatened to introduce an amendment that would eliminate all federal funding for San Francisco if San Francisco moved forward with this. So that, he never really had a chance of making that happen, but it definitely got everyone's attention, including, our member of Congress, Nancy Pelosi, had to get involved. And it made everyone extremely gun shy around here and unwilling to even mention the word supervised injection. I literally had health department staffers tell us that they were forbidden from discussing this, even if members of the public brought it up at community forums. So that, at least for me, and at least in the US, is kind of where all of this started, both with an engaged community and health department, an absurd and ill-informed response from right-wing and right-wing media, and it's taken us a long time to come back from that.
So taking a few steps back, as though we're like fifth graders, what is a supervised injection facility? What is or a supervised consumption space that it's now being called? What is this thing that people need? And can you sort of describe like what the need really is?
So a supervised consumption facility, and they go under so many different names: overdose prevention sites, community health engagement locations, and we can talk about what the different names mean, but they all basically mean the same thing, which is a location where someone comes in with the drugs that they're going to use and have a safe, clean place where they can use those drugs without fear of being arrested, don't have to rush their shot. And if they overdose or if they suffer any other uh, unexpected side effects, there'll be someone there, a trained person on staff, who's able to intervene, reversing an overdose in particular, but who can also provide other assistance, whether it's referral to wound care or advice about injection technique. And then the other thing that all of the sites have in common is they have something that's sort of a recovery room or a chill out room where people will go after they've used their drugs. And that's where there's a real opportunity to engage with people. So they're often staffed with peers, social workers, just an opportunity to check in with people, see if there's something else going on with them, if there are other resources that they can be connected to. So overall, it is taking what individuals are going to be doing anyway, but instead of injecting on a sidewalk or in a public bathroom, for example, they're going to do that in a safe, clean, sterile environment. And it's a place where people are welcomed, where they're given the kind of dignity and respect that they often don't get on the streets, and are connected, if they want, with other services.
This is Christopher Maraff from Philadelphia. So I'd like to jump in real quickly around sort of the evolving nomenclature on how we discuss this. So here we've adopted the term comprehensive user engagement sites. Some advocates have decided they're going to use overdose prevention sites. But this seems to reflect two different ideologies around the way supervised injection facilities should work. And you've got one side that sort of is, we give people a safe place to use, we prevent overdoses, we save lives, period, or we provide medical care, right? Then there's the other side that kind of sees this as ultimately a pathway. The only way to sell this is if like we can spin it into a pathway to eventual treatment, right? So when I talk to users on the street about, what do you think of a supervised injection facility? Would you use one? The kinds of things that people ask are, well, it really depends on what kind of hurdles are put in front of me. I'm not going to give my name. I'm not going to go to group 3 days a week. There are women that need some privacy because they have to inject in areas that would require them to expose themselves. I guess there's sort of an amalgam of different ideas of what this would look like. And I suppose a good question for you would be, what would your ideal facility look like? And to me, I even add housing to that. There's so many different aspects of the problems that plague this community. What does your ideal supervised consumption site look like?
My ideal site is one that has the lowest possible barriers to entry. We want people to come in and feel comfortable and feel respected. Not everyone wants to stop using drugs right now, or maybe ever. Not everyone wants to be in recovery, but everyone wants to be safe and have a place where they can do their drugs in a clean, safe environment. And so that's what it needs to be at a bottom line, is a place where people feel welcome, where they feel respected and are able to meet their needs as they define them. one of the things that I really appreciate about Insight in Canada and the research that's been done there is they are able to show that a significant number of people go on to treatment, and a significant number of people who go to Insight stop using drugs altogether. It's one of the statistics that I cite all the time, that people who use Insight are more likely to go to detox and more likely to stop using drugs than people who don't go to Insight. But, that is possible in part because people are not being pushed or pressured to go into treatment. There's no requirement to do groups. There's no, limit on the length of time you can be there. One of the things we know is the easier that we make it for people who use drugs to go into treatment, the more likely they are. If we make it really difficult and complicated with lots of barriers, or lots of assumptions or anything punitive, that those are all things that make it harder for people to go into treatment or get on methadone, for example, or buprenorphine. So you want, if people use supervised consumption services as a way to get to other services and achieve other health goals that they've set for themselves, that is fantastic. And that is, that's a large part of why I do this work. But there absolutely cannot ever be any requirement that people go to treatment, that they go to groups, that, we can't, if we put that expectation on the individuals who are using the services or the services, we will have failed from the very beginning.
One of the biggest arguments against supervised injection is that it's enabling drug use. But one of the things that I've seen from researching this and reporting on it for a couple of years is that it's really about restoring human dignity. It's giving people back their humanity and being like, yeah, you may be injecting yourself with these drugs, but you're a human being and we're going to treat you with respect and we're going to try to make it as safe as possible. This idea of supervised consumption is so controversial, but we've had syringe exchanges in the United States, syringe access programs for decades, and it really just seems like it's the next logical step. Instead of, we have so much data that shows giving people clean syringes reduces overdoses, reduces harm to their arms, reduces the transmission of bloodborne diseases. This is just the next logical step by saying, hey, we're giving you some needles, go use them. We'll make sure you use them correctly and don't harm yourself.
Yeah, it's like a syringe exchange inside. Like, it's not that complicated.
Exactly. It's just adding another room to a syringe access program. When people, I'm a longtime volunteer here in San Francisco with the syringe access services here. And, you give people syringes and then you tell them to go inject somewhere else. And if people are homeless or any other reason why they don't have a safe indoor place to inject, they're going to be injecting on the sidewalk. And it's, syringe access is only part of what people need. They also need that location. And if they don't have a safe location, they'll do it outdoors in somewhere that's less safe.
On that note, I'd like to point out that, in many ways, Philadelphia has had its own sort of crowdsourced supervised consumption site for years. And first it was, a camp in West Kensington called El Campamento, which was, which was stocked with clean needles through outreach. It was, once Narcan became available, there was abundance of Narcan there. When that population got sort of pushed to these bridge encampments, it was there were more user to user reversals, I believe, than EMT or police reversals. Most of the reversals I've witnessed always were user to user, with EMTs and police showing up later. This is not ideal, obviously, but is there any talk about a middle ground of where we sort of train users to be their own roving supervised safe injection facilities in a way, because no, obviously every city is different. At least where I am, that's the perception I've taken away from the clustering that's been going on of users. But you're always going to have people that use alone, and that's probably due to socioeconomics. If you have a home, you're maybe going to go to it. If you have a car, you're probably going to sit in it. I guess I'd start by asking you that, in lieu of perfection, what should people that care about this be doing?
Yeah, drug users have always saved each other's lives. Every effective harm reduction intervention that we have in this country was created by and for drug users, and then eventually it gets, bureaucratized and sort of sterilized and expanded to the mainstream. But syringe access started with people who use drugs. Peer distributed naloxone certainly started with people who use drugs, started with Dan Big. And the same is true, of course, of supervised consumption services. There have always been places where people got together to, share information, to share drugs, to keep an eye out for each other, to make sure that someone had Narcan on hand. So in a lot of ways, this is just expanding on what drug users have always done to take care of each other. And, as you probably know, there's an unauthorized underground supervised consumption program somewhere in the US that is run by drug users. And, I do think that having people roving around with Narcan and syringes and being able to sit there and, be a witness, be a support, be ready to intervene if necessary is a great idea. And I think a lot of people already do that. One of the sort of underlying pieces around this, certainly here in San Francisco, I imagine it's probably similar in Philadelphia, is that all of this is happening on the back of a ridiculous housing crisis where affordable housing is so hard and homelessness is going up and homeless people are becoming more visible. But it is also true that people who are living alone may be in some ways at more risk for overdose. So you've got to kind of fix a lot of different parts of this.
I think one of the points you made that is constantly left out of the debates is okay, first, there already are semi-supervised consumption sites in operation all over the US. There's definitely a couple that are being ran by people who just are doing the right thing. They don't have permission. They have, again, these are unsanctioned, but people are still doing it. And then the flip side to that is there are already unsanctioned supervised injection sites all over too, like in San Francisco, in Philly. I'm in Chicago, and the West Side is one gigantic unsanctioned site. And so we're talking about people doing what they're going to do, and then we're also talking about people who, without permission, are doing what they feel like just needs to be done. And that's sort of where this debate, or maybe that's where things have sort of stalled for a while. That's where things are now. And I just want to read this paragraph from Rob Rosenstein's op-ed in the Times, which so perfectly summarizes where we're at. His logic is so bizarre. He starts, quote, "Proponents of injection sites say they make drug use safer, but they actually create serious public safety risks. Many people addicted to opioids use illicit fentanyl or one of its analogs, which can be up to 5,000 times more powerful than heroin." Chris, is that right? 5,000? Users often have no idea what they are actually buying from criminal drug dealers. Moreover, a bystander or emergency medical worker who comes into contact with such drugs can be gravely harmed. This entire paragraph is batshit crazy. Because there's fentanyl out there, people are already injecting it all over the place in unsupervised ways.
I know, and
you have to bring it indoors. You have to follow them. We have to get them inside. He just made the point for the opposition.
Well, and I really want to hear Zach in particular go on a rant about fentanyl and bystanders. But, and if he doesn't, I will. But, it is so patently absurd and offensive to, the reason we have fentanyl is because of drug prohibition. The reason people are buying illicit drugs that they don't know what's in them is because of prohibition. Like, prohibition is the single largest harm here. We're trying to mitigate some of the harms of prohibition, and to have someone from the Department of Justice, like the biggest upholder of the war on drugs in this country, turning around and somehow trying to blame the victim of their policies for taking these actions just makes, steam come out of my ears.
Exactly. Yeah. No, I mean, that's so true. I mean, in Philly now, we've had a few outbreaks of synthetic cannabinoids winding up in bags of dope. That's troubling to me for a number of reasons, but I don't believe it's intentional. We're still in the early stages of figuring out why that's happening. But I do try to emphasize that everything that we use, whether it be test strips, supervised consumption sites, needle exchange, is all just really workarounds, or as a friend of mine has called it, you can look at it a different way, as a beachhead towards getting the real impediment to safety, and that is prohibition itself. Laura, I would like you, if you would, just give us a quick rundown of to the extent you can, the status of the cities that most prominently have come out in support of this. I mean, Seattle, I think, was the first, and then I could discuss Philly a little. We did it a little uniquely here, and I've had conflicting feelings about that that have evolved. But why don't you just run down the primary cities that are potentially going to be the site of whatever federal intervention the DOJ has in its mind?
There are 5 cities where city government has said they want to do this, and that is Seattle, San Francisco, Ithaca, New York City, and Philadelphia. The other cities where there is some amount of local organizing, meetings, work, includes Portland, Oregon, Denver, Colorado, Baltimore, Boston, definitely. Washington, D.C. has been having some conversations. LA is interested. The LA City Council actually endorsed the statewide bill and said that they're interested in starting something. I should probably put them on the first list. So those are the main cities. I know that there are a number of states, Vermont and Maryland, as well as Massachusetts, Colorado, California, Missouri, had some legislation that hasn't gone anywhere. There are a number of cities in Maine that are interested, as well as in Vermont, Western Mass, as well as Boston. Those are the main ones. Chicago's been having some conversations about this. It's, essentially any urban area where there's a sufficient concentration of sort of public drug use and or a significant number of overdose deaths are starting to look at this.
I'd like to just clarify one point. Philadelphia has actually made it very clear that they're taking a hands-off approach to this, at least at this point. Publicly, and this is where a sort of a personal conflict came in with me, is publicly they basically said, we will not run, we will not manage, we will not fund, or to use Rosenstein's term, subsidize a supervised injection facility. However, if anyone should do such a thing, we support this idea and we will not do anything to interfere with it. I was at that press conference and I asked the managing director, so what happens if a group of medical students decide to do this tomorrow? And he said, well, we'd like to talk to them. At first I saw that as sort of a half measure. It was kind of like leaving, all these people out there without any official support to potentially find this money, put together a facility, take all the risks, find their own defense should something go wrong. But as time has gone on, I've seen it as more of an opportunity in a way, that that the city itself has sort of like left it into private foundation hands. But even they aren't entirely clear on how that's going to work, because with every step that gets taken towards a discussion or a dialogue around this, city officials seem to adjust their position, into now, like they'd like to now see what a protocol might look like, etc. However, they, as of the official record, Philadelphia will not use any public money to subsidize supervised consumption.
Seattle has already appropriated city money to spend on it. In San Francisco, I know we're looking at private funding for it to avoid using taxpayer money, although I certainly think it is the responsibility of the city to fund this, so I want the city to be funding it. And in New York, I know they're looking at creating it as a research project, which is a different way of doing it. It's really interesting to me the ways that cities and community groups and advocates are being creative about trying to find their ways around different problems as they pop up.
One thing that I want to address is that this idea is so controversial in the United States, but it's really not in a lot of other parts of the world. I mean, you have Canada. They have a couple dozen supervised consumption sites, some that have been existing for as long as 15 years. They're in Australia, all over Europe. I mean, it's not an uncommon idea. I believe there's more than 100 out there.
Our latest count was 120, around 120. It's a little hard because they keep opening, and also because Canada has sort of two different types, the supervised consumption services, and then the even lower threshold overdose prevention sites.
And those are sort of like the user ran satellite sort of sites,
Yeah.
right? Yeah.
Yeah, just a tent in an alleyway sort of thing.
Most of the experts in public health and law that I've spoken to about this subject believe that we're heading towards a test case, not unlike a Roe v. Wade, say. I mean, do you think that we'll find the right plaintiff in the right city that's willing to be the face of this issue and potentially do years in jail as this goes through the courts?
I hope we don't have to go for that kind of a defensive litigation strategy, but I mean, I wouldn't be surprised. One of the things that I say here in California a lot is that, if Assembly Bill 186, the California Supervised Consumption Services Overdose Prevention Bill, passes and the governor signs it, it has passed. If the governor signs it, it'll essentially put this on the same footing as where we are with marijuana. So right now, San Francisco licenses on-site consumption of a federally Schedule I controlled substance in a handful of locations around the city. And those are the marijuana dispensaries that have on-site consumption licenses. And this is, in many ways, no different than what's happening there. And, marijuana is treated under federal law the same as all these other substances, which is absurd, but that's a different conversation altogether. The feds have certainly tried to come after different states around medical cannabis, around cannabis, but they've never gone after an elected official or a city official or a state official for any of these. So, it's while the stigma that relates to injection drug use is much greater than that attaches to people who use cannabis. I would be surprised if they actually came after a city official. I think that sets up a bigger conflict than even this administration wants. I think they mostly like just doing some sword rattling, saber rattling. So, we'll see. I wouldn't be at all surprised if there are at least a series of arrests for this. And, I cut my activist teeth on civil disobedience with ACT UP back in the day. So, if we have to do that again, we certainly can. I hope we don't.
One of my concerns is that this this op-ed from Rosenstein is going to scare away injection drug users. If a supervised consumption site were to open, I mean, they're getting this message like, I don't know if they'd feel comfortable even using it. I mean, would the DOJ be just sitting there with handcuffs waiting for them to cut the ribbon? It seems like it's taken a long time as well. There's been a lot of tepidness from people that are, will they or won't they? Who's going to open it first, kind of thing.
In Travis Lupik's book, Fighting for Space, there was like just such a really good layout of the Vancouver sort of history and fighting for insight ultimately. And the people who did that, who really got it, they were so nervous that when they opened it, people weren't going to show up. Like the Vancouver, like Vandu, the drug user network there, if they didn't support insight and these people were organizing drug users, if they weren't saying like, no, insight's safe, like you're going to be good, you're not going to get arrested. Like if they weren't doing all this sort of community building and stakeholding behind the scenes, like it wouldn't have worked. And that's the thing about a lot of these things, is that like naloxone distribution doesn't work unless you get it into the hands of drug users, and things like this don't work unless the people who the services are for are bought in, right? And I think that's so much of what this work really is about. And I think that's the stuff that, you know, Laura, you've been doing for decades.
You know, the people who use drugs are actually they're at the same level of legal vulnerability as they are when they're out on the sidewalk. I mean, they could be coming to the attention of the feds and facing federal charges that they wouldn't otherwise be. But, you know, they sort of face less risk in this than the people who own the property and are running the program, which doesn't mean, I mean, it's, you know, it defeats the entire purpose of providing people who use drugs with a safe space if it's not at all safe from them being arrested. So that, you know, it's not worth doing if it's putting people who use drugs at greater risk of harm, because that's what we're trying to avoid.
And I think it's important to keep in mind that we're talking about a specific subset of drug users that are usually homeless or have housing instability, that are on the street a lot. There are many users that drive in and drive out, and they're not going to be they're not going to be pulling their car into the parking lot of the supervised injection facility and waiting to get trailed, you know, back to the highway. But we can attack the, you know, where the crisis is really happening here, and you know, and I think that that's important to make that distinction, is we're dealing with the most marginalized of a population that includes many other different strata of people that use drugs. Laura, has this pronouncement from the DOJ, how has it been met by your colleagues and your peers? Has it changed the conversation, emboldened it?
Yeah, there was nothing new in there that we hadn't heard before. You know, various U.S. attorney generals have, in different states, have.
It was a weak ass argument.
On this. The DOJ has no business weighing in on the best way to address a public health crisis. This is a public health crisis. It deserves public health interventions. The criminal justice system has no business saying what we should or shouldn't be doing around this to begin with. So there's that problem. I mean, he's woefully misinformed about what the programs are, and his specific op-ed was full of factual inaccuracies and quotes from, you know, random people in Washington State as if they had some like stance in this. But it wasn't at all surprising. The fact that the New York Times, which has previously done their own editorials in support of supervised consumption services, was willing to publish this is a little bit. But, you know, there was nothing surprising about this. It definitely got people's attention. And in some ways, I think it's raised the level of conversation around this. Like, people are more interested in finding out what these programs are because of it. And I think, you know, it may well backfire on this administration for trying to, add this to the list of things that they're making various fact-free assertions about and then proven wrong.
I think Rod Rosenstein wrote this to remind everyone that he's a good Republican and, hey, don't fire me. Like, I believe in the same things as you guys, and this is him coming out, and because he's part of the quote witch hunt, and there's so much other like bullshit politics going on at the DOJ, and like Trump's like nativist disgusting faction of politics is sort of like at war with the DOJ or something, and there's all this weird sort of like the Russia investigation, like all this stuff is I feel like weirdly in the backdrop of this, because people only know the Deputy Attorney General, people only know Rod Rosenstein because of the Mueller investigation, because Sessions recused himself from the Russian probe. Like, there's so much stupid shit going on right now, and I feel like this is Rod Rosenstein just being like, I'm a good conservative, don't fire me.
And when it comes to Donald Trump, I think he secretly would very much like drugs to be legal and to be in the business. That's ideologically, I think he probably stands inside his own head where he did in 1993. But he simply can't say that now. But I can't say for sure. He's an opportunist. He's not an ideologue.
Yeah, he has the understanding of like a fifth grader about this, but you're right. In the 90s, he was like, the war on drugs has failed. We got to legalize it. He did say that.
So, Laura, I suppose we've kept you a while. Is there anything that you'd like to, close out with that maybe, we've missed or that's missing from the conversation that our listeners need to hear?
I mean, I think, regardless of what this administration does, cities and states are going to move forward. We've lost so many people to overdose deaths, and it's meant that a lot of, grieving family members and concerned public health officials and so on are starting to actually reach for other solutions beyond what we've been doing. And, it doesn't take much looking for other solutions to find supervised injection services, because they are so evidence-based and heavily researched and common sense in other countries. And I think, I really hope we don't have to lose another 72,000 people to overdose before we start actually providing solutions that work, like stronger naloxone distribution, and, greater access to methadone and buprenorphine, but also to supervised injection services. So, every day that we delay opening these programs, more people are dying, and we can't wait much longer.
Thanks for listening to Narcotica. You can follow us on Twitter at Narcocast or on narcocast.com. If you like the program and you want to support us, there are two ways. First, give us a decent rating on iTunes so others can find the podcast. You can also find us on SoundCloud, Stitcher, and soon Spotify and other platforms. Second, you can sign up at patreon.com/Narcotica and become one of our patrons. A little goes a long way, so we really appreciate the Patreon listeners we have. Plus, if you donate $5 or more, you'll get access to exclusive bonus content. If you want to send us suggestions, tell us about that one time you took way too much acid, man, or just drop us a line, you can email us at tips@narcocast.com. Narcotica is an independent production by Christopher Maraff, Zachary Siegel, and myself, Troy Farah. Our co-producer is John Ahrens, and the opening credits music is by Glass Boy. That's all, folks. Talk to you again soon.